Great. Hello. Okay, here is our first slide. So, my name is Taavi, Saviauk. As you kindly mentioned, I'm the CEO of our startup, Unitary Healthcare. I have a background in medicine and I'm also an engineer, so like both worlds are familiar to me. And Satu-Liisa is a pediatric surgeon, and now she's working as a deputy chief physician in Finland's biggest emergency department, Tampere's Akuta. I have actually, this is not, the topic is a bit general, but I have actually more like a case how we managed to get our idea and our product to public healthcare, and how we managed to start our first pilot, which is now running in Tampere and surrounding health centers. But I'm gonna tell you briefly what's the product, what we are piloting in, and how it went from the idea to current state. Our software, UOMA, is basically it's the communication tool for non-urgent patient transfers. Currently, if we want to move the patient from emergency department or from a department in hospital to another hospital or another health center, we have to do all the communications by telephone, by calling the receiving party. Even if we want to know if there are any places that we can, our patient can be treated, we have to call and ask for the receiving party that if they have places. There might be like 50 to 100 phone calls containing only the information of available beds coming to health center, which is a lot, and it causes problems, it causes costs. And we had the idea that we can reduce those phone calls, and we built a cloud-based software, which we call UOMA, which is basically the communication link between the sending and the receiving party. It can be inter-hospital, like inside the hospital, and externally to another hospitals or health centers, or to another organizations. What the receiving party does is that they update the available beds, so the sender can automatically see if they have any available beds, so it removes all those calls. And the sending party enters the patient's information and current status. The patient's describes the patient's information in the checklist style. That is the patient ready to move to another hospital or to the ward or wherever the patient moves. That's about it. If you want to see more, then we have a booth there, so you can come and ask more after the presentation. We will be there today and tomorrow, and you can try also this system. We have a demo version of there, so I can show you how it works. But I'm gonna tell shortly how we got from an idea to current state. First of all, at the end of 2015, we got this idea. We got this with we have 3 doctors in our company, including me, and 1 programmer and 1 small software house that does the coding and is acting as a technology partner for us. We had this idea at the end of 2015. We thought that there are like a lot of problems in the healthcare and the processes. There are very much of them, and we had before the end of 2015, we had talks with the other founding doctor and his friends that something should be done. It wasn't this idea that we were solving, but we had the tools, we had the guys and the tools, that something had to be done. And with this third doctor, we came up with this idea about these patient transfers, that they are like currently, there's still about 400,000 non-urgent patient transfers in Finland currently, like last year. So we had the idea that we should build a tool that removes these communication problems between them. And that was it. That seems doable. That seemed like it was idea that is doing only the one thing, the patient transfers. So with our small team, we thought that it's doable. So let's try to do this. So then we like polished a bit our team. There was a few guys more, but they left, and now we have these 3 doctors and 1 programmer and 1 small software house. We realized that we couldn't do this by ourselves because we had only 1 program and none of our doctors can write code. So we had to get a technology partner, and we had a few options, and at the end we partnered with Metosin, which is actually the employer of this, our 1 founder, the programmer's employer. So it's a bit complicated relationship, but it's a good relationship. And the next negotiations, this was at the beginning. We knew that if we are going to do it, we have to have a real public healthcare system where we pilot the software. It's not like not reasonable to do only the software and then to start think that can we do this? Can we even go to this public healthcare sector? But fortunately, since we are doctors and we are from Tampere, so we managed to get contracts with Tampere University Hospital. It was Satu-Liisa and your colleagues that we managed to get contract with. Actually, it was like a great adventure game because it wasn't like, this seems easy, but actually it took some 8 months. It was like a great action game when, not action, sorry, adventure game. When you have a door, you open it, you get another name. Oh yeah, that sounds great, but you should ask her, okay? Then you go to that door and then you get the response, oh yeah, that sounds nice, you should ask her. And then if you're gone through like 20 doors, then you end up back to the first one, and then you know, okay, yes, this is going to happen. Of course, our product needs to be used in at least two parties, the sending and the receiving party. So we had to negotiate with receiving health centers too, and city hospital, and so on and so on. It was a lot of negotiating. And at the same time, this is like, these all were done at the same time. Like in startup, you do everything at the same time. It's like, this wasn't like sequential flow, it was done all the same time. But we had to define this MVP. So the minimum product that we can use. It's not reasonable to build a great big product and then just to know that, okay, you cannot do it there, but still you need to have some functions to it to work, to the program to work, because if you are going to use it in a real setting, that means that it has to be working. You cannot provide them some buggy software that doesn't work, because otherwise you don't get the second chance at the healthcare system. You just don't. So at the last summer, we started programming. We had defined the MVP. We started programming the software, and the programming went quite smoothly. It wasn't much late. Of course, negotiations, they continued, and after like 5 months of programming, we finally got our pilot started. And at that time, we also had names in the paper, so we launched at the beginning of December. And actually, after that, this has been, the pre-launch time was much harder because the software itself seems to work. We have had 2 crashes, and they are both our own like bugs. There were just like accidents, and they were like 15 minutes to 30 minutes downtime, which is quite good for like public sector healthcare because they do crash a lot more. And now we are trying to expand, we are expanding in Pirkanmaa, inside the hospital, Tampere University Hospital, to wards. We have now 1 vascular surgery department, started 2 weeks ago, and now we are expanding in hospital, so we can transfer the patients from the emergency department to hospital departments, and from these wards, these departments, externally to bigger amount of health centers. That was brief timeline. Now Satu-Liisa will tell also briefly what you have to do to pilot software in public healthcare.
Thank you, Taavi. Can I have the device, please? Okay, so like Taavi mentioned, we are a very busy accidents and emergency department, A&E. 350, 400 persons go through us every day. Not all of them need a bed, but most of them need a bed in our hospital or in a health center or another hospital. So what I would advise for your startup, maybe, what you should do, you have to understand that the current systems we are working with, they don't help us a lot. We have a lot of problems. So they have often poor usability, and this causes serious problems, and it can increase morbidity and mortality even. I'll give you one example. We have this patient data system, and if, for example, I'm working in A&E and I see a patient who has fallen and hit her head, and I examine her and I think that, okay, I need a CT scan of the head. I go to the computer, I have maybe 5 or 6, 10 different patients there. I choose her, but I have to use another system to put the radiology request on there. And it's just one click that I make and it goes to a different person. And this has happened, unfortunately. So we have CT scanned a wrong head. So these are the problems that we are facing. So all the systems don't help us. So we need very, very easygoing systems, if you wish. As clinicians in the public sector, we don't want any high-quality, high-tech devices, or we would want them, but we mostly want to solve the current problems. So talk to the clinicians, go to the baseline workers, the doctors and the nurses, what are the problems here? And they will tell you, rest assured. Of course, the key to success, what is the basic, what you need to have is to have a clinician or the end worker who uses the device when you are designing it. Where you have to communicate. It is crucial because for, Taavi and the company, they are all doctors, so it was easier. But of course, if you're an engineer, we can communicate and make it work. We might have something, oh, I really wish if only I could have this. And it might be very easy to make a solution for that. Then we have to understand that different units have very, very different problems. Our problem in A&E is overcrowding. It is crowded every evening. And not only there are too many patients coming, but there is what we call exit block. So we don't get rid of the patients fast enough. So the beds are taken. And that's a big, big problem. But in another specialty, another ward has totally different problems. So ours is this, and there are hundreds of reasons that cause crowding. But if you tackle one, it can help a lot. Money, of course, you know, it's very regulated. We don't have much money. We have so much less money than the private sector. And then, of course, competitive biddings and rules, you have to do everything by the book. But then, I would give you just one advice. Do not try to make a big difference, make a big innovation. Just make it small, solve one problem, and make a small product. It's easier for you to sell the product for us.
Nice. Thank you, Satu-Liisa. So, every good lecture has to have a take-home message. And our take-home message is, this is for the startups and the last is for the public sector also. So if there are representatives, then this is a problem we faced. First is find a real problem. Don't try to build some ear lights or whatever they are building. Don't do that. Make it doable because you don't have resources. And then you have to concentrate on one thing. And then everything takes time. I mean, a month is a minimum unit. Usually takes several months. Nothing happens. People like to have meetings and drink coffee and like to have meetings and so on. So be prepared to take time. Thank you. There was a this is our system. I can leave it here and you can have an idea what it looks like. Thanks.